This is Lecture 08, Dysrhythmias and High-Yield Board Traps. The emergency department job is to determine stable versus unstable, recognize the rhythm pattern, choose the right medication or electricity, and avoid the classic board traps like AV nodal blockers and pre-excited atrial fibrillation. The objectives are these. First, apply the stable versus unstable framework as the first fork. Second, recognize narrow complex and wide complex tachycardias. Third, know the dosing anchors for adenosine, amiodarone, procainamide, magnesium, calcium, and bicarbonate. Fourth, distinguish ventricular tachycardia from supraventricular tachycardia with aberrancy. Fifth, manage atrial fibrillation, rate, rhythm, and anticoagulation decisions. Sixth, handle bradycardia, AV blocks, and pacemaker issues. And seventh, avoid the classic board traps. The ED mindset is that the rhythm is a symptom. Always ask, is the patient unstable? And ask, is this primary, or is it a manifestation of sepsis, pulmonary embolism, acute coronary syndrome, hyperkalemia, thyroid storm, or drug toxicity? Treating the rhythm without finding the cause is incomplete care, and the right diagnosis with the wrong sequence is a board trap. The first fork is stable versus unstable. Instability means hypotension, shock, ischemic chest pain, acute heart failure, or altered mental status caused by the rhythm. Unstable tachycardia with a pulse gets synchronized cardioversion. Unstable bradycardia gets atropine, pacing, or pressors based on response. Pulseless rhythms enter the ACLS arrest algorithm. Do not delay electricity for medications when the patient is unstable. Narrow complex tachycardia, with QRS less than 120 milliseconds, is divided by regularity. Regular narrow rhythms include sinus tachycardia, supraventricular tachycardia, AV nodal reentry or AV reentry, atrial tachycardia, and atrial flutter with regular conduction. Irregular narrow rhythms include atrial fibrillation, atrial flutter with variable conduction, and multifocal atrial tachycardia. Pattern recognition drives management. Sinus tachycardia is a marker of pathology and needs the underlying cause treated, not a beta blocker. Board buzzwords. AVNRT is the most common paroxysmal SVT in adults and is typically a regular narrow tachycardia at 150 to 250 with no visible P waves or a pseudo R prime in lead V1. Orthodromic AVRT conducts down the AV node and up the accessory pathway, producing a rhythm indistinguishable on the surface from it. Multifocal atrial tachycardia, 3 or more distinct P-wave morphologies with varying PR intervals, is the ITE classic in COPD exacerbation and theophylline toxicity. Atrial flutter classically conducts 2 to 1 at a ventricular rate near 150. Adenosine slows the AV node and unmasks the sawtooth flutter waves diagnostically. Stable supraventricular tachycardia management starts with vagal maneuvers. The modified Valsalva maneuver, with leg elevation and supine repositioning after strain, is more effective than standard Valsalva. If vagal maneuvers fail, adenosine is the next step. Adenosine is 6 mg rapid intravenous push, followed by a saline flush. If unsuccessful in 1 to 2 minutes, give 12 mg. A second 12 mg dose may be given. Warn the patient. Brief chest pain, flushing, and a sense of impending doom are normal. If SVT persists or recurs, calcium channel blockers or beta blockers may be used in stable patients without contraindications. Unstable SVT gets synchronized cardioversion. The classic distractor, giving adenosine to a wide irregular tachycardia that turns out to be pre-excited atrial fibrillation. It can degenerate to ventricular fibrillation. Adenosine is contraindicated in known WPW and should be avoided in irregular wide complex rhythms. Also avoid in severe reactive airway disease, where it can trigger bronchospasm. Next step when adenosine fails in stable narrow regular SVT is a calcium channel blocker like diltiazem or a beta blocker. Never both stacked, given the risk of additive AV block and hypotension. Atrial fibrillation in the ED requires 3 questions. First, is the patient unstable? Those with rapid ventricular response get synchronized cardioversion. Second, is this primary AFib or a marker of another illness? Sepsis, pulmonary embolism, acute coronary syndrome, thyrotoxicosis, and alcohol withdrawal can all present with AFib. Third, what is the duration and stroke risk? AFib less than 48 hours may be considered for rhythm control with lower stroke risk. AFib over 48 hours or unknown duration requires anticoagulation strategy before cardioversion in most cases. Board Pearl, atrial fibrillation is the most common sustained dysrhythmia in adults. The most common underlying causes of new onset AFib tested on boards are hypertension, valvular disease, particularly mitral, hyperthyroidism, alcohol, the classic holiday heart, pulmonary embolism, sepsis, and acute coronary syndrome. Whenever new AFib shows up, screen TSH and consider PE, especially if hypoxia or pleuritic chest pain is present. Mimic to know, atrial flutter with variable block looks irregular and gets misread as AFib. The sawtooth flutter waves in 2, 3, and AVF are the giveaway. Atrial fibrillation management has 3 pillars. Rate control, cardizem 0.25 milligrams per kilogram intravenous, repeat in 15 minutes if needed, then infusion. Low pressure, 2.5 to 5 milligrams intravenous every 5 to 10 minutes. Avoid both in pre-excited AFib, severe heart failure, or hemodynamic compromise. Rhythm control, synchronized cardioversion, 120 to 200 joules biphasic, for unstable patients or selected stable patients within the appropriate window. Anticoagulation, use CHAD's 2-VAS score to assess stroke risk. A score of 2 or greater in men, 3 or greater in women, typically warrants long-term anticoagulation. Use HAS-BLED to assess bleeding risk. The board principle is that AFib management depends on stability, duration, and stroke risk. Trial trivia, the ITE loves, the AFIRM and RACE trials showed no mortality benefit of rhythm control over rate control in stable chronic AFib. Boards reward picking rate control as the default in older stable patients. The next step, PEARL. In acute AFib with rapid ventricular response and borderline blood pressure, magnesium 2 grams intravenous over 15 minutes is a safe adjunct that slows the rate without dropping pressure the way cardizem can. Always check potassium and magnesium before chemical conversion. Low magnesium and low potassium both blunt the response and prolong the QT. WPW with atrial fibrillation is a board emergency. The ECG, irregular wide complex tachycardia, changing QRS morphology, often very fast. AV nodal blockers are contraindicated. Adenosine, Calin, beta blockers, digoxin, and cardizem. They block the AV node and accelerate accessory pathway conduction, which can trigger ventricular fibrillation. Treatment, procainamide 17 milligrams per kilogram intravenously over 30 minutes for stable patients. Synchronized cardioversion for unstable. The board trap is reflex cardizem. WPW ECG buzzwords, short PR under 120 milliseconds, delta wave, widened QRS. The most dangerous distractor on boards, digoxin. It shortens the accessory pathway refractory period, accelerates conduction, and can cause ventricular fibrillation and death. The correct answer is procainamide or synchronized cardioversion. Wide complex tachycardia with QRS 120 milliseconds or greater is ventricular tachycardia until proven otherwise in adult patients with risk factors. Unstable patients with a pulse get synchronized cardioversion, 100 to 200 joules biphasic. Pulseless ventricular tachycardia gets defibrillation in the ACLS arrest algorithm. Stable monomorphic VT may be managed with amiodarone, 150 milligrams intravenous over 10 minutes, then infusion, or procainamide, 17 milligrams per kilogram intravenous over 30 minutes. Most common cause of sustained monomorphic VT on boards, ischemic heart disease with myocardial scar. The reentry circuit forms around the old infarct, so an older patient with a prior MI and a wide regular tachycardia is VT until proven otherwise. ITE buzzword, procamio trial favored procainamide over amiodarone for stable monomorphic VT. Fewer major adverse cardiac events. Stop the infusion if QRS widens by more than 50%, the QT prolongs, or hypotension develops. Distinguishing VT from SVT with aberrancy is hard. Features favoring VT, AV dissociation, fusion or capture beats, QRS over 140 milliseconds with right bundle morphology, or over 160 with left bundle, extreme axis deviation, precordial concordance, and history of structural heart disease or prior infarct. The Brugada algorithm walks 4 steps. Absence of RS in any precordial lead, R to S interval over 100 milliseconds in any of those leads, AV dissociation, and morphology criteria in V1 and V6. Any single yes calls it VT. The Verrecki criteria look at initial and terminal QRS forces in AVR. A dominant initial R wave there favors VT. Do not confuse this algorithm with Brugada syndrome, a sodium channelopathy with COVID ST elevation in V1 through V3, sudden cardiac death risk, treated with an implantable defibrillator if symptomatic. When in doubt, treat as VT. Anti-VT therapy is safer in SVT than the other way around. The board principle, wide complex tachycardia in an adult with cardiac risk factors is VT until proven otherwise. Treating VT as SVT with Calin or other calcium channel blockers causes hemodynamic collapse. Torsades is polymorphic VT from QT prolongation. The ECG shows a twisting QRS axis. Stable patients, Magnesium sulfate 2 grams intravenously over 5 to 15 minutes. Repeat as needed. Correct hypokalemia and hypomagnesemia. Stop QT prolonging medications. Overdrive pacing or isoproterenol helps bradycardia-dependent cases. Unstable polymorphic VT gets defibrillation, not synchronized cardioversion. The rhythm is too irregular to synchronize. The board trap. Amiodarone further prolongs the QT and worsens torsades. Congenital long QT syndromes. Board favorites, Romano Ward, autosomal dominant with isolated QT prolongation, and Jervell-Langdon-Nielsen, autosomal recessive with congenital sensorineural deafness plus long QT. Acquired causes are the ITE meet: hypokalemia, hypomagnesemia, hypocalcemia, bradycardia, plus drugs, macrolides, fluoroquinolones, methadone, antipsychotics, tricyclic antidepressants, and antiemetics like Zofran. Lab nuance. Check ionized calcium too, not just potassium and magnesium. Next step in pause-dependent cases after magnesium, isoproterenol or overdrive pacing to shorten the QT by raising the heart rate. Symptomatic bradycardia, atropine 1 mg intravenously, repeat every 3 to 5 minutes to a maximum of 3 mg. If atropine fails, transcutaneous pacing, dopamine 5 to 20 micrograms per kilogram per minute, or epinephrine 2 to 10 micrograms per minute infusion. Transvenous pacing is definitive for unstable high-grade block. Identify reversible causes: hypoxia, hypothermia, hyperkalemia, drug toxicity from beta blockers, calcium channel blockers, or digoxin, inferior myocardial infarction, and elevated intracranial pressure with Cushing response. The board concept, bradycardia plus instability, is an emergency. Atropine is not the answer for every cause. It is typically ineffective in high-degree blocks, Mobitz 2 and complete heart block, because the block is below the AV node, where vagolysis cannot help. Go straight to pacing in those rhythms. Sick sinus syndrome buzzword, tachy-Brady syndrome, alternating supraventricular tachycardia and symptomatic bradycardia, classic in older patients, ultimately needs a permanent pacemaker. Lab Pearl. Check potassium in any bradycardic patient on dialysis, an AC inhibitor, or spironolactone. Hyperkalemia with peak T waves and a widening QRS is a board favorite hiding under symptomatic bradycardia. AV blocks have predictable patterns. First-degree block is a prolonged PR over 200 milliseconds, usually benign. Second-degree Mobitz type 1 shows progressive PR prolongation until a drop beat, often AV nodal, and usually does not need pacing. Second-degree Mobitz type 2 has constant PR with intermittent drop beats, infranodal location, and high risk of progression to complete block. Third-degree complete heart block has AV dissociation with the atrial rate faster than the ventricular escape rate. Mobitz type 2 and third-degree block need pacing pads on, transcutaneous backup ready, and cardiology involvement for transvenous or permanent pacing. The board concept is that the pattern predicts the location, and the location predicts the risk. Mobitz 1, Venkabach, classically follows an inferior MI from right coronary artery occlusion with AV nodal ischemia and is usually transient. Mobitz 2 and new bifascicular block in the setting of an anterior MI suggest infranodal damage from a large LAD territory infarct. Those patients need pads on immediately and frequently progress to third degree. Next step Pearl, in symptomatic Mobitz 2 or complete block, the answer order is pads on, transcutaneous pacing, then transvenous, not trial atropine and wait. Classic distractor, picking atropine as the next step in third degree block. It rarely works and delays definitive pacing. Pacemaker patients in the ED require structured assessment. Modes: ventricular paced, V, atrial paced, A, or dual. Common ED issues include failure to capture, pacing spike without QRS, failure to sense, inappropriate pacing into intrinsic beats, oversensing, and pacemaker-mediated tachycardia. Magnet application converts most pacemakers to asynchronous mode, which can be diagnostic and therapeutic for some failure modes. Implantable cardioverter defibrillators should not have repeated magnet application without electrophysiology involvement. The board concept is that a PACE patient with new symptoms deserves an ECG and device interrogation. Electrolytes and toxins drive rhythm emergencies. Hyperkalemia with ECG changes. Calcium gluconate 3 grams intravenously or calcium chloride 1 gram intravenously comes first. Then shifting therapy, insulin with glucose, beta agonists, bicarbonate if acidotic, and potassium removal. Tricyclic antidepressant overdose with QRS widening. Sodium bicarbonate 1 to 2 milliequivalents per kilogram intravenous bolus, repeated for QRS over 100 milliseconds. Digoxin toxicity with hemodynamic instability or hyperkalemia over 5. Digoxin specific Fab fragments. Calcium channel blocker or beta blocker overdose. intravenous calcium, glucagon, high-dose insulin euglycemia therapy, vasopressors, and lipid emulsion. Always involve poison center. The board trap, treating TCA-induced wide QRS with antiarrhythmics instead of bicarbonate. Synchronized cardioversion is for unstable tachycardia with a pulse. Energy anchors, stable narrow regular, SVT, atrial flutter, starts at 50 to 100 joules biphasic. Unstable narrow irregular, AFib with RVR, starts at 120 to 200 joules. Wide regular VT with pulse starts at 100 joules. Defibrillation is for pulseless VT, VF, or polymorphic VT that cannot be reliably synchronized. Use maximum biphasic energy, typically 200 joules. Sedate the patient if time allows, but do not delay the shock in extremis. Pad placement. Anterolateral is standard. Anterior-posterior may improve success in refractory cases. The rhythm board traps are predictable. Treating compensatory sinus tachycardia with AV nodal blockers when the patient has sepsis, hemorrhage, or pulmonary embolism. Giving cardizem in pre-excited atrial fibrillation. Ignoring hyperkalemia and bradycardia with QRS widening. Treating torsades with amiodarone instead of magnesium. Treating VT as SVT with Kalen, which causes cardiovascular collapse. Forgetting that rhythm correction does not end the search for the underlying cause. Delaying electricity for medication in an unstable patient. Magnet on an implantable defibrillator without EP awareness. It can disable therapies. On a permanent pacemaker, magnet converts to asynchronous mode. Cardizem is the wrong answer in WPW with atrial fibrillation. Case 1. A 22-year-old presents with palpitations and presyncope. The ECG shows an irregular wide complex tachycardia with variable QRS morphology and a rate over 250. Blood pressure is borderline. This is pre-excited atrial fibrillation in WPW until proven otherwise. Avoid AV nodal blockers. Stable patients get procainamide 17 mg per kilogram intravenous over 30 minutes. Unstable patients get synchronized cardioversion. EP referral is mandatory after stabilization. The board trap, reflex cardizem, which can precipitate ventricular fibrillation. Case 2. A patient on antiemetics and antibiotics develops syncope. Initial ECG showed QT prolongation. Now the ECG shows polymorphic VT with a twisting QRS axis. Stable patients get magnesium sulfate 2 grams intravenous over 5 to 15 minutes. Correct potassium and magnesium. Remove offending medications. Unstable patients get defibrillation. The board trap is amiodarone, which further prolongs the QT and worsens the rhythm. Question 1. A patient has unstable regular narrow tachycardia with hypotension and altered mental status. What is the next best step? The answer is synchronized cardioversion, starting at 50 to 100 joules biphasic. The trap is adenosine in an unstable patient when electricity is the right answer. Question 2. A patient has bradycardia at 35 beats per minute, peaked T waves, and a wide QRS at 140 milliseconds. What is the first medication? The answer is intravenous calcium, either gluconate 3 grams or chloride 1 gram. The trap is atropine alone, while hyperkalemia drives the rhythm and continues to threaten the patient. Question 3. A patient has irregular wide tachycardia in known WPW. Which medication should be avoided? The answer, any AV nodal blocker, cardizem, Calan, adenosine, beta blockers, and digoxin. The trap is reflex cardizem, which can accelerate conduction down the accessory pathway and cause ventricular fibrillation. The final takeaways are these. The first fork is stable versus unstable. Patients in the unstable group with a pulse and tachycardia get synchronized cardioversion. Adenosine is 6, then 12 milligrams for stable narrow regular SVT. Pre-excited atrial fibrillation gets procainamide or cardioversion. Never AV nodal blockers. Torsades gets magnesium, not amiodarone. That drug prolongs the QT and worsens the rhythm. Hyperkalemia with ECG changes gets calcium first. Wide complex tachycardia in adults is VT until proven otherwise. AV blocks Mobitz 2 and complete heart block need pacing readiness, and the rhythm is a symptom. Always look for the cause. References for this lecture include Rosen's Emergency Medicine, 10th edition, Foundations of Emergency Medicine Board Review, the American Heart Association, ACLS Guidelines, the American College of Cardiology, American Heart Association, Heart Rhythm Society Guidelines for Atrial Fibrillation and Ventricular Arrhythmias, the Modified Valsalva Maneuver Evidence, Revert Trial, and Poison Center Resources for Toxin-Driven Rhythms. Local institutional protocols for cardioversion, transvenous pacing, and antiarrhythmic dosing guide site-specific decisions.